Well, welcome everyone to the Journal Club. I'm not going to introduce the speaker. I have the honor of introducing our new board member for the Pediatric Society, Odion Kalatsi. Yeah. I almost did it. But I want to introduce myself. I'm Brian Evoy. I'm the new executive director for the Pediatric Society. As you know, Stephanie, long time leader for the organization, has retired. And I'm sure all of us will want to do that someday as well. So wishing her well on that. Just want to remind you that we've got three important purposes for this society. And the first one is to improve infant, child, youth, and family health. The next is to be involved in negotiations for the Physician Master Agreement. And the final is pediatric education, and that's why you're here tonight. Without further ado, I'll pass it over to Odion.
Thanks a lot, Brian. Appreciate that. Look forward to being on the committee with you. I do want to introduce Dr. Joseph Lam, who's here today. He is a clinical associate professor in the Department of Pediatrics and Dermatology at UBC. He is the chapter author of 5 textbooks on the field of pediatric dermatology, as well as an associate editor for the Pediatric Dermatology Journal. And in addition to treating children with atopic dermatitis, he has also had the personal experience of having it during childhood himself, and one of his children has had a severe atopic dermatitis, so he brings that aspect of it too. So please welcome Dr. Joseph Lam.
Thank you very much. So thanks for having me speak. We'll talk about atopic dermatitis, something that I'm sure you see all the time in your practice. And the title is Top 10 Tips for Atopic Tots and How to Manage Childhood Eczema. For this talk, feel free to stop me at any point. We'll have a question and answer at the end. But as the talk goes on, if you have questions that come up, just let me know. There's even, I think there's things you can push so that your voice will be captured for the people dialing in the webinar. So I've disclosures with different companies. To mitigate that, I'm going to talk about products in a very generic form. And so objectives of tonight, we'll talk about the concept of the epidermal barrier and skin inflammation in causing or triggering atopic dermatitis. We'll discuss the importance of moisturization in preventing atopic dermatitis and how this is very important for the maintenance and treatment of our patients, and provide some useful clinical and resource tools for educating and treating atopic patients. But first thing is tip 1, watch out for atopic dermatitis mimickers, because not all that itches is atopic dermatitis. And here, the word eczema is very interesting. It comes from the Greek word exene, which means to bubble or boil over. And in the acute phase of eczema, you can see this kid who's young, who's drooling, weepy. It looks very, it's like it's boiling over. But a lot of different things can give an eczema-like reaction where it looks like the skin is boiling over. So here's a picture of 6 kids who have things that look kind of like the skin is bubbling or boiling over, but they all don't have eczema, or they don't have just atopic dermatitis. So can anyone guess what this patient has over here? Contact, exactly. He's had contact to the belt buckle. He's a nickel allergic chronic dermatitis. How about this kid who's very itchy with this line here? A lot of different things are possible. Molluscum is possible. In fact, that's what this patient has. And with molluscum, you can get a dermatitis around the molluscum that looks very eczema-like, but it's triggered by the molluscum. This one, everyone is itchy in the family.
Oh, it's
scabies, yeah. And then if you actually do a scraping, and this is from this kid, you actually see the scabies mite. I find it's useful to do the scraping because you can have it swimming in your microscope, and then I bring the family over, because I'm not sure if it's happened to you, but sometimes I tell patients, everyone needs to be treated with permethrin. I say, really? But it's so expensive. If they see the scabies mite floating there, everyone gets treated. You know? And this one here is molluscum dermatitis. Oftentimes for patients with molluscum contagiosum, if they have, especially if they have a history of atopic dermatitis, they can develop an eczema rash around the molluscum. It's important to recognize that too, because you still treat the eczema the same way. But some patients who actually don't have eczema can actually get this dermatitis around the molluscum, and you want to make sure that you know what you're treating. There's a funny story from the previous head of dermatology, Harvey Louis. When he was a resident, he was on call for children's, and he had this kid that he was called for in the hospital, and he had this localized eczematous eruption in the axilla. So he called Margaret Johnson, who was the peds derm person at the time, and said, oh, this is the history and this is that. And then she said, thanks for the great history and physical exam. Can you go back and count how many molluscum this patient has? It's like, what? But I was explaining atopic like eczema. So he went in there, and sure enough, the patient had molluscum contagiosum. So something from the history tips it off, but it's not rare to see eczema around where the molluscum is. Here, the molluscum is fairly obvious. Sometimes the eczema can be much more obvious. Now, this kid, what do you think this kid has here? Coxsackie or herpes, right, because both of them can look very similar to this. And this is a kid that had HSV. So this is eczema herpeticum. And the difference here is this kid did have a history of atopic dermatitis, but you see these punched out erosions or ulcers that are here that are fairly monomorphous. The funny thing with these patients is that if you swab them, you'll find Staph aureus, and sometimes you think, oh, it's bacterial superinfection, I've got it. But they don't get better. And the reason why is that it's eczema herpeticum. That's been superinfected with Staph aureus. But as about 5 or 6 years ago, we've seen a different strain of Coxsackie virus, not the usual A16, but the A6, which can give something that someone creatively called eczema coxsackium, because it can look like eczema herpeticum, and that's something that we see also. And sometimes to differentiate this, it's pretty good here. They do PCR, so you can get you can know if it's HSV or not. How about this kid over here? Scaly annular eruptions, and she has a kitten in the house.
Ringworm.
Ringworm, right? This is Tinea corporis, and if you, interesting for scabies, you don't need a high-powered microscope. Even like a Toys R Us microscope will do, because the scabies can be seen. But if you're going to do a scraping for a KOH, you need a high-powered microscope. But then you can actually see the hyphae right there. You know, this is Tinea corporis. And who knows what this is right here? Behind the ears. Seborrheic dermatitis is definitely possible. Quite thick over the scalp. Psoriasis. This patient has psoriasis. But you can see that even though this is classified from a derm point of view as a papillosquamous disease, it can look very similar to atopic dermatitis. And the funny thing is, you know, eczema is very, very itchy. But if you ask your psoriasis patients, psoriasis can be itchy as well. So don't let that fool you. But it's usually more bright red, and the location is a bit different for psoriasis. So that's tip 1. Make sure, you know, if you're treating a patient, make sure it's eczema that you're treating. Tip 2 is that education is very important for your patients, and it can be very therapeutic. If eczema was like an infection, you treat with antibiotics and it's gone, you just tell them, take this, finish your course, and it's done. The problem with eczema is it's a chronic disease. It's something that will come and go, come and go, and come and go. So having the patients understand what's going on with eczema, understanding the course of eczema is very, very important. Otherwise, you have the case where just last week I had a patient that came in. They're appropriately treated for the atopic dermatitis, but their complaint was, my doctor gave me this medication for my eczema, or my kid's eczema, and it's not working. So I said, well, how long does it take for the eczema to clear up? Oh, we put it on, it clears after 3 to 4 days, but it comes right back. So then for that patient, it's explaining what the time course for eczema should be and what we can do, what we can't do. And it's worth taking the time to go through the basics of eczema. The thing with eczema is that it takes a long time sometimes to educate the family. But if you front load that education, you'll find that oftentimes they understand how things work, they try it out, and if it works, they don't have to come back again and again. Where sometimes they just say, oh, use this, and they do that, but then they say, I'm not sure if it's good. And their friends tell them, oh, steroids are bad. Oh, watch out for this. It can cause, you know, problems. And like, oh, I'm not sure what to do. And they do this, and things aren't working. Like maybe it's the food. They get all confused. But if you set a framework and say, this is what should happen, and see if it follows that framework, and it does, you can guide them along. And sometimes, if you do that, they aren't looking to other things like getting sidetracked by foods or other things that may be distractors for these patients. So sometimes for patients, I tell them, hey, do you want the Coles Notes version or the PhD dissertation? Because some people will say, you know, just fix it. I need some sleep. Other people say, I've read all this stuff on the internet. What do you think about this? And you're like, well, sit down. We'll talk about that. Sometimes I tell the families, you can, even if you're done your education, but you can thank, little Johnny for enrolling you in the School of Eczema, because there's a lot to learn, but my job is to make sure that you graduate and have everything you need to know to treat the kid's skin. And it's very important for your patients too, because if you can educate them, they sometimes don't even come to our office. There's nothing that we do in dermatology that you can't do yourself, aside from maybe biopsies and getting to that point. But a lot of eczema patients you can manage, and you do manage very, very well. So what causes eczema? It's good to let them know it's multifactorial. There's genetics that's involved. And a lot of the genetics we've discovered over the last 10, 15 years involve the skin barrier, the flagon gene, how that when that comes together, if you're missing that gene, either one allele missing or both, you can have very, very dry and sensitive skin. But the environment has a lot to play as well. Some people who have, flagrant deficiency, but they're living somewhere where it's very, very humid, sometimes they don't have any eczema at all until they come to Vancouver. And even though it's very wet here because it rains, I mean, thank goodness for today where it's nice and sunny, but it's wet, but they still get dry skin. The reason why is it's cold, and then the heat turns on and the air gets dry. We have some families where they come in, all the parents have dry skin, but only when they've come here. And the kids all have eczema. If the parents are born here, they probably would have had eczema as well, but it's because of the environment that's different. So one way to explain it is you can either draw, with my EMR, I have a computer with me, I pull up a picture of a brick wall. I use my fingers, like this is a brick wall. If you think of the bricks, those are the skin cells that are there. And in between the skin cells, you have the mortar. And that's the natural moisturizing factor that the body produces. But if you have atopic dermatitis, many of these kids have partial or complete flagellum deficiency. If you have that, the mortar isn't working well. So what does that mean? It means that water that's inside the skin can evaporate or leave the skin, leaving the skin much drier. But it's a two-way street. So if water gets out, irritants on the outside can get in as well. And that kind of helps conceptualize things. That's why moisturizer is very important. You're giving the child what the child's skin isn't making on its own. But I sometimes also conceptualize it saying, if your body's producing it all the time, you always have it. But if you're putting it in from the outside, the best, thickest moisturizer isn't going to last for more than 4 hours. This is why you have to continue to put the moisturizer on. And sometimes if they're a baby and they have bad eczema, you'll see it's everywhere except for the diaper area. I mean, who's seen that? You open the diaper area, it's like almost like a line right there where the eczema stops. When you see that, that's a good way to explain. It's kind of like that skin in the diaper area. It's not uncommon when kids are older, if they're in underwear, they can get eczema there. Once it starts, you can get the regular eczema. But in the diaper area, it looks good because the diaper is doing what the skin can't do. It traps the moisture in, keeps the irritants out. And one way to explain moisturization is like, well, it's kind of like full body diaper therapy. You can get the skin to look like that if you moisturize. Can moisturization prevent eczema? It's very interesting. They asked this question even before we had the food prevention studies with, early introduction of peanuts. They thought, well, think of that example, that patient that came from, say, Southeast Asia, where they have eczema there, but this family where no one had eczema until they came over here, the parents never even manifested with eczema. And maybe that's because of the moisturization that they had. So Eric Simpson, who does a lot of work in Oregon with eczema, he said, well, we'll try to get this large study of a whole bunch of infants, enroll them in. And then early on in 2014, he had pilot data from about over 100 infants say, wait, if we can moisturize the kids who are at high risk for eczema, high risk defined as if you have a sibling with eczema, your chance of getting eczema if you're the next kid is up to 40%. But the regular background rate is about 20%. So let's enroll these infants and then get half of the patients kind of single-blinded to have the parents moisturize the kids within the first 3 weeks of life, at least once a day, and see what happens. And what happened here, this is between Oregon and the UK, they found that if you moisturized every day, by the time the kids were 6 months of age, the control group had what we expected, about 43% of the infants had eczema. But in the ammonia group, that was a half to 22%. So maybe we're delaying the onset of eczema, maybe we're kind of masking how eczema presents, how it looks, but at the very least, you're making a difference for some of these kids by moisturizing them early on. And this is a Japanese group that did a similar thing, and they found that they can decrease the incidence or the diagnosis of eczema in these infants if they just moisturize. All it was just moisturization. So it's really important to moisturize the skin of these patients. If you understand what's going on, what they're missing, it kind of makes sense why that works. And it's also important to set realistic expectations, saying, I can't cure your child's eczema, meaning I wish you just stop eating these 5 foods and the eczema is gone. But it doesn't happen that way. I wish I'd give you a cream and it's gone. But it comes back. And same thing with any pills that we do, it'll come back. However, we can control it very effectively. And the difference is that well, one way to explain it is that if you just take a piece of paper and draw on one axis, this is how bad the eczema is. Up high is bad, down to the bottom is no eczema, and this is time. What eczema does on its own is it comes and goes, comes and goes, comes and goes. And usually the parents are nodding because they know that the cyclical, pattern of eczema. But it can be really bad to the point where it can, some kids, they're itching and scratching, they can't sleep because of their eczema, or they're bleeding because of their eczema, or they get infection because of their eczema. We can prevent all of that. And the way to do that is whenever the eczema is there, you want to have something that's effective to put out the fire of eczema. So if you use the analogy of the skin as like a dry town, and eczema, like fires are breaking out in that town, when the fires are there, you can do something about that. And if you have good therapy, you start the medication, you should be able to put the fire out very, very quickly. if it's the right medicine. And with the fires out, you stop putting the water on because there's no point putting water where there's no fire, and just wait. But it's important to know that I haven't changed how sensitive the kid's skin is. It's still going to flare up, but when it flares up, if you get on top of it right away, a small fire is much easier to put out than waiting for it to be a big fire. And with that, a couple things happen. Number one, the child's not living in these big flares up here anymore, so you don't get those terrible side effects of having eczema by itself. But the second thing that happens is that you're not using the medicine continuously. You're using it on and off, on and off. So sometimes it's kind of like telling the parents, the kid's young, yeah, there are going to be fires that break out, but you'll be like the firefighter there to put out those fires. And that's how we can control the eczema effectively. And with that, it dispels the myth that, use a cream, the eczema's gone forever, like that patient that came in. No, the eczema's going to come back. We can't stop it from coming back. We can do different things with moisturization, but it's going to come back. But when it comes back, we can make it go away very quickly. We can make it seem as if your child doesn't have eczema. It's very interesting because if you look at the history of topical steroids, they've only been around from about 1952. So before that time, yeah, some dermatologists call it, BC and 80. Now it's not BCE, like before corticosteroids, after corticosteroids. And like with all medicines that we're doing, it came from the rheumatologists. They had cortisone, and they used that for a lot of rheumatological diseases. And someone found a preparation they call it preparation F, I think, or compound F. And that was hydrocortisone that came out. So it's very interesting how that came out. And before that, we'd use things like tar, or even other things that were like tar is pretty, it stains, it smells. Some people even suffer with their eczema until they get older. And sometimes parents say, I want you to do what you can to make sure he doesn't have eczema so he has nothing. But it'd be great if he didn't have eczema, but we cannot do that. But what we can do is, if we just leave him like the way he is, he might outgrow it. But those 1 or 2 years, if he outgrows it, they can be really tough years for your child and for yourself. What we can do is make those years seem as if he doesn't have eczema until he outgrows it. And that's kind of that framing it in that way to let parents know what to expect. And also to let them know, yeah, it's a long-term control we're looking for, not just a quick fix for their eczema. So it's like the old Home Depot commercial, you can do it, we can help. That's the phrase for eczema. And tip 3 is it's probably not the food, and definitely there's no role for empiric food avoidance, like just cutting out the food. This is very different from what you read if you look at mommy's groups or blogs. Foods can worsen eczema. And what happens is that irritant chronic dermatitis is really, really common. So you have babies that are drooling. Sometimes their cheeks get very bad. That's irritation from their saliva. But the same thing, food can do the same thing as well. So oftentimes, especially if you have eczema skin, like sensitive skin, or if you have active eczema, if you're eating foods that are more acidic, foods that are more irritating, so like oftentimes patients say, oh yeah, foods that are not necessarily the ones that make you think of anaphylaxis. So some people say, oh yeah, tomatoes make it worse, citrus fruits make it worse. It's the irritant effect. And one way to think about that is, well, if I fell off my bike and I scraped my cheek, if I had a lemon and rubbed on my cheek, it would sting. The same thing's happening to the kid, but I'm not allergic to the lemon. Or you can use the example, if they have the drool dermatitis that's there, it makes the eczema worse, but your child's not allergic to her drool. It's just the irritant from the drool. Same thing with the foods. And if that's the cause, the treatment is very different than avoiding the food. It's just protecting the skin. Now, kids with eczema, particularly severe eczema, are higher risk for true food allergies. So in that case, it's pretty obvious to say it's not the food directly causing the eczema. It's the food giving the anaphylactic signs, including urticaria or hives. And when you're scratching that, you can make eczema pop up. But there it's pretty obvious that's the case. What is not very common, yes?
I had a child, the parents using a lot of coconut oil, and
Right.
ended up being allergic to coconut.
Yeah.
And CeraVe eczema wash, I learned through Joanne Young,
Yeah.
has wheat in it.
It does, yeah.
And the child became sensitized to wheat.
And that's a big thing because we find these days, especially from the allergy world, that it's kind of like a race to see which immune system sees the allergen first. If you see it through the gut first, your immune system is more likely to say, hey, this is a food, don't fight it. But if you see it through the skin first, the immune system is more likely to say, oh, this is foreign. So if it sees it through the gut the next time, it might say, okay, we got to fight this. And this is probably why in the kids with atopic dermatitis, number one, they're higher risk for food allergies because it can pass in through the skin. Of my 4 children, the only one that has food allergies is the one that had bad eczema when she was a kid. And it's probably related to that. But also, if you introduce the food early, that's where you might actually mitigate that and get things under control. But yeah, sensitization through the skin is probably very important. Even before the stuff came out in humans, they showed that in rats, where you can actually sensitize rats through the skin even before they've eaten it through the gut. And then, so that can happen as well. So what you put on the skin is very important. Coconut oil, oftentimes, if you have oils that are there, depending how they process the oil, if it's cold pressed, the proteins are probably still there. But if it's heat processed, then the proteins are usually destroyed. If you ever used, there's fluocinolone oil, which is a common oil that's used for eczema. It's actually in peanut oil. But the reason why it doesn't cause peanut reactions, people have peanut allergy, is because it's heat processed. So there's no protein of the peanut whatsoever. Every so often I still get calls from the pharmacist like, oh, your patient has peanut allergy. Are you sure you want to prescribe this? Like, it's okay. Yeah, exactly. And then what the company did, they were bold enough to even say, for our early studies, we're going to choose peanut sensitized and peanut allergy patients to use this medicine on, because it's not going to happen. So, but yeah, so then, but if it isn't, and there's a form of coconut called, it's very interesting, if you ever read labels, and if you ever work with someone like Jillian DeGans, who does contact dermatitis, all these things with long names, all the different components there, the different things your body can actually get an allergic contact dermatitis to, not even a systematized anaphylaxis to, but there's one called cocamidopropylbutane. There's too many syllables for one word, but that's made from coconut oil, but it's synthesized in a way, so it's modified as a preservative or as a surfactant for a lot of products. But that's where people can actually commonly get an allergic reaction to. I think only in the past year I've seen one kid that was IgE positive to coconut, and they had used coconut oil because I think it's the popular oil these days to use. But sometimes I tell patients, yeah, it sounds like it's safer because it's natural, but poison ivy is 100% natural. And if it's botanical, it doesn't necessarily give it a free pass. Most times, companies, they're not served well if the product's going to cause rash, but just know that just because it's from a plant doesn't mean it's safe. So yeah. So yeah, foods can cause highs, but non-IgE mediated true exacerbation of eczema is actually quite rare. So if that's quite rare, meaning that you eat the food and you don't get the anaphylactic symptoms, but your eczema flares, and it's just the eczema flares and nothing else. So if that's not, it's very time and labor intensive to do a double-blind placebo-controlled food challenge. You select patients who really think it's the food, and you make sure that no one knows what it is, and you feed the child, and you kind of monitor them over a few days, because sometimes the reaction doesn't happen immediately. When you look at those studies, people who are convinced, less than half of them will have a reaction. Oftentimes the reaction isn't even eczema, it's other rashes that come up. So if you look at that, it seems like it's not common, but why do people report it so much? One possibility is that eczema is a cyclical thing. It comes and goes and comes and goes. And because you eat foods all the time, you can always look back and say, I fed my child this food and the eczema flared. You want to trust your observations, but just realize that it could be just a chance association because it's happening all the time and because you're feeding foods. And sometimes it's the patients who have the more severe eczema where they're looking for different things. They're grasping at straws because if their eczema isn't managed well, they're willing to do anything to get sleep, to get things under control. I think the fact that babies, sleep deprivation, you can make people do just about anything. And in those early years, I think, for kids, just go to sleep, please. Same thing with kids with eczema. Sometimes you're like, anything to help my kids sleep and help me sleep as well. But I have some families that come in. Fortunately, it's not very common, but they come in saying, we're only eating 3 or 4 foods because eczema is so bad. And these foods make it worse. But sometimes it's good to just point out, if this is as good as you can get it, and the kid's still itching and scratching with tons of eczema, maybe we can do something better. But they are grasping at straws. So it's good to listen to your patients. But sometimes it could be just the fact that it's temporally associated, but not causing it. So how do you sort that out? A good way to sort that out is, if it is due to a true allergy, every time you have that food, you should have a reaction. Otherwise, it's no point, linking it to the food. So instead of looking back and saying, which foods did I feed, or which food did I eat and feed my baby before the eczema flared, try to get the eczema as good as possible, and then challenge the food. If it's not anaphylactic, if it's not IgE mediated, challenge it at home. You don't have to do it in a hospital. The skin test is not going to be helpful. It might probably throw you off a different way and see what happens. A lot of families who are totally convinced it's the food, if they give the food when the eczema is good, and the first thing is to clear the eczema, because if the eczema isn't good, then different things can make them scratch. Even foods have natural histamines in them. So if you eat a food that has natural histamines, you might scratch a bit more. You want to clear the eczema first, have them eat the food, and then nothing happens after a few days. And you say, good news. You can eat that food and that's fine. You can go through the foods and you can reintroduce things back in the diet. The allergists, even, they, in their recommendations, in the States, there's sometimes a bit more about saying, oh yeah, maybe it's a food allergy. But they're, in a review even 10 years ago, said despite their frequent use, there's little good quality evidence to support the use of exclusion diets in atopic eczema. And recently in the derm literature, the role of elimination diet in atopic dermatitis, if you look at it, it's commonly used, but the evidence for it is actually very poor. Concerns are you might unnecessarily limit a food, but if they're eating, I don't know, not eating tomatoes, it's not the end of the world for the patients, but rarely you can have some that can have protein calorie malnutrition. Fortunately, it's not that common. The thing that's probably more important is that this concept of tolerance, which has come out, with the peanut stuff that we know. If you withhold that food, even if your body has been somewhat tolerant to the food, you actually might develop a true allergy to the food by withdrawing it. And this is where we see, this is that a concept of if you get oral exposure first, your gut immune system may see the food, and when it sees the food, it says, hey, this is a food, even though it's foreign, let's not fight it. It's just a food. But if your skin sees it, and you can imagine this picture is supposed to show the kid with the right side of the kid having more eczema. If these cutaneous allergens can get in through the skin first, and your immune system sees it there, your immune system in the skin is probably going to say, this is not a food. This is something that's foreign. You need to fight it. So if it's sensitized, next time you eat the food, the body says, no, we got to fight this. So withholding the food actually may even be dangerous for the patient from an allergy point of view. And this come out, the stuff with the LEAP study with peanut consumption showing, hey, if you introduce these foods early, and one of the high risk groups were people with severe eczema, you can actually decrease the incidence of peanut allergy in those groups. And that kind of all ties in with the same thinking. But how foods can worsen eczema? Well, if it is urticaria as part of an IgE-mediated symptoms, then you want to be careful because this could be the sign of anaphylaxis. Sometimes the first time could be a bit milder and it could be more serious the next time. And specific IgE testing or skin prick testing is something you want to consider because these patients are at high risk for true food allergies. If it's irritant contact dermatitis, then just protect the skin. That's all you need to do. If it's non-IgE mediated, it's hard to do a true double-blind, placebo-controlled food challenge. What you can do if the parents are like, no, I'm sure it's the food, you can do this thing where I just print out a calendar for the family and say, you know what, have one of the parents decide which days of the month to give the food and just do that. The other parent, don't tell the other parent what day you're giving the food and have them rate the eczema on the same chart and just tick, 1 tick if you have a bit of eczema, 3 ticks if it's really bad. And, if you're giving the foods only on a Saturday and you're rating the eczema with, oh, these are supposed to be ticks, but pretend like instead of ticks you have sheets of paper. Or this is like, the eczema isn't that bad and it's really bad here. If you look at it and you find that, oh, I'm giving the food on the Saturday, but it's, the eczema flares here, 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 there's no relationship with the eczema. So you can actually see it in front of you and say, oh yeah, it doesn't make a difference. But if you find that, every day, if you're giving the food and the day after, it keeps flaring up, then maybe there's something to it. It's good to listen to your patients, and even if it doesn't happen for a lot of patients, it might happen for some. So yeah, it's good to, but I find that the majority of the patients, if they do that, they find it doesn't have any relationship. Actually, they don't have to even go through the whole month. They do it a few times, they realize, oh, the eczema really isn't getting worse. Sometimes it's very interesting. My memory, if I look back, I forget sometimes even what I have for breakfast or what, when I've done something. It's very easy to have a filter to think of the past and have it fit my concept. But if you go forward and you actually objectively look at it, a lot of patients can see, oh, it actually doesn't make a difference. And it empowers them to know, okay, it doesn't make a difference. It gets even trickier when they do IgG4 testing and it shows them all these foods that show up. And sometimes I say, oh, the important thing is the IgG4 tells you if you've eaten the food or not. Some people even think it might be protective antibodies, so you don't have to worry about that. But instead of trusting what a sheet shows, know what the test is supposed to do. We're trying to predict what happens when you eat the food. If you eat the food, nothing happens, or it doesn't happen consistently, you don't have to eat the food. It can be very liberating for a lot of patients to know that. Tip 4 is counter medication phobia. And the proper use of topical medications is very important. I like to use the analogy of putting out a fire, because big fires, small fires, you put it out. And one way to do it is that sometimes if you just use a small little Dixie cup and put out the fire, it's going to take forever to put out that fire. If you use a big bucket, it's gone really quickly. I tell the patients, That's how you want to put out the eczema. You can just put a little bit of medication, or if it's the fire's going down, you can kind of like, use a little bit less and a little bit less. But if you do that, you're just prolonging how long the fire is there, and you're prolonging how long you're using the medicine for. You want to put it out right away and put it out quick. Two things happen. Number one, your child is not itchy, your child's feeling better quickly. The second thing is you're using the medicine for a short period of time. If you want to get to cutaneous side effects of the medications, we're particularly talking about topical steroids, you have to use something that's very potent, but also for a long period of time in an inappropriate area. We're talking for most medicines like 2 or 3 months continuous. So if you clear something within, a few weeks, you're totally fine. And if you don't clear, think, is it really eczema? Go back to the first point, what am I treating here? And is the medicine the right strength? But if it does clear that short period of time, it should be fine. Sometimes people say, well, steroids, it's hormones. I don't put hormones in my kids. And I say, well, you know what? Your body has natural receptors for steroids because your body actually makes steroids all the time. So then sometimes that helps them understand. Yeah, the steroids aren't made in a human and we don't extract it. It's made in a lab. But your body recognizes it because it's naturally made by your body. So then we're like, we want to get this. We want to put it out as quickly as possible and not use the medicine for a long period of time. What we don't want to do is to use something that's too weak or not enough of the medication. And if you do that, the eczema takes it's a slow decline. And what happens is that you're using the medicine for a much longer period of time, unnecessarily long. So you want to clear it fast. So the analogy is you want to put out a fire. And then sometimes I immunize against the package insert. I had some pharmacist friends. Like, maybe I should say immunize against the pharmacist. Like, no. Like, immunize against the package inserts. I tell them not all steroids are created equally. If you look, this is from Canada. This is 1% hydrocortisone, which is over the counter. If you look at this, it talks about Cushing syndrome and HbA axis suppression. That's enough to scare your families. If they Google that, they're not going to put anything on. And just today I had a patient who said, but isn't the cortisone going to stunt my kid's growth? So let me show you the talk I'm going to give today. If caffeine was a regulated substance, if you couldn't get it from Starbucks or Second Cup, and you had to get it from your pharmacist, there's a difference between espresso coffee and decaf coffee, but caffeine is still the same. In decaf coffee, there is caffeine. It's just a very, very low amount of caffeine. Is that my signal to finish? Oh, no, there we go. So there's a very, very low amount of caffeine in there, but there is still caffeine. So in the package insert, it'll explain what caffeine does. But if you go to get decaf coffee and you read that this will make you jittery, it'll make you stay up all night, it'll make you pee, you're not going to drink decaf coffee. But it's not the same, decaf and espresso. Same thing with topical steroids. There's class 1, which is very, very strong, class 7, which is very, very weak. It's not all created equally. And because cortisones as a class can have these different effects, the different concentrations out of there, the different strengths of topical steroids, it's very, very unlikely to happen with a low-class topical steroid. And if you choose the right medication for the right area of the body, you shouldn't run into problems. But the skin isn't created equally either. Your eyelid area, it's very, very thin skin, whereas the skin on the body, it's thicker. If you're dealing with the hands and the feet, even the dorsum of the hands, which doesn't feel very thick, it can get very, very thick. You have to use something that can penetrate. So it's kind of customizing the medication to different parts of the body. So it's good to educate about how not all steroids are created equally. And usually, for the hands and feet, I have no qualms using something like clobetasol, which is a class 1, because number 1, absorption is very, very low through the skin of the hands and the feet. Number 2, the body surface area is very, very low. But number 3, that's an area of very, very thick skin. But usually I get calls from the pharmacist saying, are you sure, is it okay? And sometimes I tell the family, this is the right one you filled out. The pharmacist, eyes get bigger and they ask you, is this the right one? And have them call me. Or in my handout, I circle, this is the one you can bring to the pharmacist and they'll know. It's good. I think, having pharmacists or healthcare professionals that are a bit more cautious is not a bad thing because they're caring about the patient. But sometimes it's good to let them know it's okay, it's the right thing. It's good to educate about post-inflammatory hypopigmentation because I can't tell you how many times patients come in with this and said, I had to stop the medication because it's causing skin thinning. It's like, I have good news. That's not skin thinning. When you put the medicine on, you put it on all over. And if you look at it, it's not all over where you put the medicine. It's just where the eczema is. This is from the eczema. If you want to see skin thinning, this is skin thinning. This is an adult that's been using a class 1 topical steroid for about 2-3 months on the leg. You can see it, not only is it lighter, the skin is sunken down in this area. There's telangiec changes or dilated blood vessels. There's bruising, there's purpura. That's skin thinning. And fortunately, it's not that common to see in kids, but it is also reversible. Something else that is a mistaken identity. I took a picture of this kid when he was younger because he has these cheek telangiectasias, but he's never had topical steroids in his life because he didn't have eczema. I saw him for something different. But I saw those cheeks, like, I gotta take a picture of cheeks, because if he did have eczema, you'd probably say, oh, it's the topical steroids that's causing the telangiectasias. And this is him older. You can still see a bit of it if you look, but it's not as obvious. Whereas this kid came in with this picker's nodule. I think he had a mosquito bite or something there. And some kids, you know, they're professional pickers. They just keep going at that. So someone prescribed him like a mid or mid-high potency topical steroid. It helped a bit with the itch, but because he was still picking, you can see that he has one very prominent blood vessel that's there. And that's the thinning that we're talking about with the topical steroids. For him, I switched him to a non-steroid. Within 2 weeks, it already settled down. But that's what we're talking about, not this, which is really common in kids. So brief history of topical steroids, 1952, first introduced. One of the most important milestones in dermatology. It's anti-inflammatory and anti-proliferative effects. But interestingly, a few years later, the first reports of adverse effects emerged, where people were using it in the scrotal area and like, oh great, we can use this, it works great. And then they started seeing atrophy and thinning that's there. And children are at potential increased risk of side effects because, you know, kids are not little adults. And because they have a higher body surface area to weight, you can absorb more. However, that's a nice beard. The flip side is adults and kids are similar in some ways. If you look at the skin itself, the thickness of the stratum corneum after the newborn period, it's very similar in kids and adults. And the structural components of keratin and lipids are fairly similar. All to say that even though there is a theoretical risk of systemic absorption in children, under normal conditions, most topical steroids are not absorbed, and they're even metabolized by the skin. And up to 99% in the daily life, it's removed by rubbing, washing, exfoliation of the skin. There are rare reports, particularly in the diaper area, if you're using a high potency topical steroid, like a class 3 or higher in the diaper area, there have been reports of kids using it to treat some dermatoses and that didn't respond. It could have even been in Canada. And after about 2-3 months, getting Cushing syndrome. But that's really, really rare. Rare enough that you get these case reports that are published because they're so rare. For most kids, it's very hard to get systemic absorption of topical steroids. So you don't have to worry about this. And this treatment for steroid phobia is education, not necessarily a change in medication, because the parents need to know that if they're afraid of topical steroids, using the right one, using the right location, and what is a side effect, what isn't a side effect is very helpful. But we do have a range of therapeutic options, not just topical steroids, which range from low to high class, but calcineurin inhibitors, as well as the phosphodiesterase 4 inhibitors as well. And then there's a recent article talking about, and this is just published recently, topical treatment for mild to moderate pediatric and atopic dermatitis. And our very own Wingfield Remus is the senior author of this, where it goes through, you know, mild to moderate eczema, through the journey. Education is huge and it's important. And moisturization is very important as well. And if they don't have red, itchy skin, you can just moisturize their skin and they're fine. But if it is red and itchy, if it's the face unfolds, there's more sensitive areas, or if it's mild, you can use a lower potency topical steroid, or calcineurin inhibitors, or phosphodiesterase inhibitors. But if it's more moderate in the body, you can use a mid-potency topical steroid. And you want to see if it's clear, almost clear within 8 weeks. Usually I set it at 2 weeks to clear. And if it isn't clear, look at adherence and see if it's infected, make sure it's not. If it is clear, then you stop, but see how often it flares. If it flares, you can think about even maintenance therapy with a steroid, topical steroid, calcineurin inhibitor, and maybe even a phosphodiesterase inhibitor. Tip 5 is prescribe an adequate amount of medication. Because sometimes you go through explaining, say, oh, you use this much and this is what you should do. But if the pharmacist only dispense like a 30-gram jar and they're due to see back in 3 months, inadvertently they think, I got to make this jar last for 3 months. But that's too little, especially if they're a larger kid or if they have a larger body surface area to treat. And the use can be proportional to the size of the tub or the tube that you prescribe to the patient. So there's a really great rule of thumb, which is the rule of the fingertip. Has everyone heard of the fingertip unit before? Yes. So about a third of the people. This is great, the fingertip unit. What the fingertip unit means, if you have a medication, say it comes from a nozzle that's about 5 millimeters or half a centimeter, if you squeeze it from the tip of your finger to the first knuckle or the first crease that's there, and this is for an adult hand, that's the medicine you need to treat 2 adult palm sizes. So sometimes having that like quantitatively describe to the patients, that can make the difference. Patients come in, they're not responding. Sometimes all they need to do is know how much to put on. If they do that, you don't need to change the medication. It's just how much is put on. Sometimes if they bring in the tub, and I like to put it on, I like to see the tub to see how much they use, because if they have, like a 100-gram tub, say, doc, I'm using this for every day for the last 3 months. You open the jar. It's like, have you refilled this? Nope. And it's like only dented a little bit. It's like, that's the good news. You can use more of the medication. It's okay. You're not using too much. But sometimes I like to put it on the patients myself in the office. When I put it on, if the parent's eyes like, that much? I know why it's not getting better. So the fingertip unit. So here's just a guide to the fingertip unit. This is pretty old. This is from like 1998, but it shows you, if you can calculate with your 2 palm sizes how much to put on. But this graph just tells you how many fingertip units you need to treat at different ages. And for example, if you have a 12-year-old child and you're just treating an arm twice a day for a month, that's 110 grams. Just to give you a sense of how much you need to use. Now, fortunately, if you're using the right medicine, you don't have to use it twice a day for the full month, but just to give you a sense of how much you need to use. Which is why sometimes, if we're using like beta-methazone valerate, the pharmacists actually have a 454-gram jar there. And oftentimes, if they're giving it to the patient, they scoop it out from that into a jar. You can just give them the 454 grams if it's like widespread eczema, and they just get that. They just put a sticker on it in the name. There you go. And it's quite useful to have. Same thing with 1% hydrocortisone. They have a big jar of that. This is very interesting. This was published almost exactly 2 years ago. This is the Canadian Pharmacy Journal, and whatever it is in French. The article is called A Practical Guide to Treating Atopic Dermatitis for Pharmacists, and they had a couple pharmacists that were on as authors, and they actually go through the fingertip unit and how it works. So this is the fingertip unit. If you're treating the front and back of one hand, that's one fingertip unit. So instead of measuring it for the child, you can just use your own, the parent's own hands to see how much it is. And just getting that practical amount there can make a huge world of difference. So the rule of thumb, 1 fingertip unit is 2 adult handprint areas, and that's half a gram that's there. Tip 6 is you don't need to limit the baths. The most important thing is the moisturization. So there's an interesting study that was done where to kind of look at the bath question, because oftentimes you say, oh, your child has dry skin, don't bathe. So there's a pediatric dermatologist in New York, and she had 2 grandchildren born within the same month in New York at 2 different hospitals in the city. And both of them had dry skin. And the nursing staff in the first hospital said, oh, your child has dry skin, so you should not bathe as often. And the other hospital, the nursing staff said, oh, your child has dry skin, so you should bathe every day and moisturize. Who was right? Well, both of them had some truth to it. If you bathe and you don't moisturize, as the water evaporates, it'll leave the skin drier. I use the analogy of licking my lips. If I lick my lips all day long, my lips are dry at the end of the day. But if you bathe and moisturize to seal in the moisture, then you're adding moisture to the skin. So this is kind of demonstrated in this this elegant study of, it was adult volunteers published in Pediatric Dermatology of 4 different groups. One group bathed and no moisturizer. The other group bathed and put moisturizer right away. The third group bathed and they waited half an hour and put the moisturizer. And the last group, they didn't even bath at all. They just put moisturizer on. And if you look at the 4 groups, this is the bath no moisturizer group with the square. That's the only group that lost water. All the other groups got hydration. They got water in the skin. In fact, the group that got the most hydration was the group that didn't even bath and moisturized. But eventually, you'll need to bathe your kids. So just to say that, yeah, if you're going to bath and not moisturize for whatever reason, well, you should moisturize. But if you're not, yeah, it makes sense to bathe less often. But if you're going to moisturize, you can bath as little or as much as you want, as long as you bathe every so often. And the important thing is moisturization. And then say, well, doc, which moisturizer? Well, at the end of the day, the Eczema Society of Canada has a whole bunch of products that say they approve, and they're a good nonprofit organization, a good patient advocacy group. But in general, ointments last longer on the skin than creams, which last longer than lotions, which are usually water-based, which is better than gels. So gels are usually formulated for hairy areas where you don't want it too sticky, but you don't want to put it in the regular skin because it's going to evaporate because they're alcohol-based. Yeah. Also, if you've scratched open the skin, gels are going to sting. So oftentimes, it's a tricky area because oftentimes the things we use for the scalp, most of them are formulated as gels or lotions that have alcohol in them, so that it'll evaporate. But oftentimes, if you scratch and it's open, it's going to sting the scalp. If you have really, really bad eczema, sometimes the only thing kids are going to put on is ointments, because both the creams and the lotions, because of the water content, they need preservatives to stop them from going bad. So then the preservatives can even just sting the skin from an irritant point of view. So sometimes ointments will work well. So tips on how to bathe. I say think of washing dirty dishes. If you have dirty, greasy dishes, then you can use hot water, a lot of detergent, soak it in the water, and then scrub it all off. Do the opposite for your kids, because you want to keep those oils there on the skin. Tip 7, ask your patients to bring in the medications, because compliance is worse than you think. You can demonstrate how much to apply, put it on. You better sense of how much is used by just opening the cap, and compliance is worse than I think. And someone actually got past ethics to do this study. And this is the greatest title, Stealth Monitoring of Adherence to Topical Medication. So ethics said, yeah, you can tell the parents that it's being used for therapy, but you don't have to tell them that you're monitoring if they're using it or not, because that would just, negate the study. And they had these jars dispensed by the hospital pharmacist that had a computer chip. So every time you open the jar, it would click, click, and they record how many clicks. So when they took the jar back, they could see how many times did they use it. And it's supposed to be twice a day. It's like going to the dentist. If you look at, this is the visit. And right before the visit, it's kind of like, I flossed my teeth when I was a kid. Now I floss my teeth all the time. But I would floss right before I go see the dentist. Compliance is pretty bad. One of the side comments from the authors are like, if someone with really, really bad compliance and really bad eczema, you can even make follow-up closer so that they know it's happening and they'll put it on. But just know that it might not be as good as you think, the compliance. Tip number 8 is very interesting. Try swimming pool baths. Help is under your kitchen sink, but it might not work the way we used to think it worked. Swimming pool baths, you add a quarter to half a cup of regular bleach to a full bathtub, soak for 5 minutes, rinse off, and repeat 2-3 times a week. This is the study that kind of broke the news in 2009. Hey, look, the changes in the EASY score, the Eczema Area and Severity Index. This is pretty dramatic. This is similar to some, expensive medications that you can use for eczema, and looked great. And the major news outlets picked it up, like, hey, baths with bleach help kids' eczema. Study shows bleach takes the pain out of eczema. Great. But then looking at it more recently, and this is from May of this year, if you look at the concentrations that we use for bleach baths, it's nowhere close to the MIC. What we're using is 0.005. It doesn't really kill Staph aureus. We're talking about like a 10 times order of magnitude, a concentration that probably irritate the skin. So what's happening? Bleach may target inflammation directly. This is a study that was done in mice, showing that it targets NF-kappa B, which is a signal for inflammation in the skin. But the funny thing is that when this study came out, people didn't say, all right, bleach may have a different effect. It came out, studies suggest bleach can reverse the aging process, because NF-kappa B is also involved in aging. It doesn't reverse the aging process. And does it really work? People looked at a meta-analysis looking at bleach baths, all the different studies, and here's the first one showed, hey, it makes a big difference, but other studies, you pull them all together, the effect size isn't that much different from just water baths. Interestingly, in both groups, their eczema scores got better. So with that in mind, I don't abandon using bleach baths for my patients. I think it does have a role, but at least in the study, it doesn't appear to be more effective than water baths alone. I think because of the cost, it's cheap. The safety, there's no really problems I have with that concentration of bleach that's there. And because it does make things better, I find it still does help for patients, but probably unlikely due to an antibacterial point of view. Tip 9 is consider the impact on the quality of life for the patients. What you see isn't always what you get. And sometimes if they have mild eczema, think, oh, it's just mild eczema. But if you talk to the patients, find out they're scratching so much, it's hard to sleep, or they don't want to wear shorts because they don't want people to see it, or they don't go swimming because swimming makes it worse. It can impact their quality of life in pretty significant ways. So some patients, they can have social isolation, and sometimes people think that's infectious. It's interesting, the Eczema Society of Canada, there's a place in there where we can print out a card saying, my child's eczema is not contagious, it's not infectious. So you can hand it out to people, so like, hey, you can play with my kid, it's fine, it's not going to be passed on. And sometimes there's teasing and bullying that can happen, but some kids do limit sports and outdoor activities, sometimes through embarrassment, sometimes through discomfort, like with swimming for some patients, or it exacerbates their disease. And if you look at the quality of life scores, it's very shocking with eczema. If you look at localized eczema, it ranks almost as bad as diabetes. And you think, how does that make sense? In diabetes, you're kind of needles all the time. But if you think about having diabetes, even though, yes, a lot of needles, a lot of finger pokes, you're in control of your disease. You're actually hyper control of everything, of your food, your intake, and your sugars. And eczema, if you don't have it under control, even if it's just localized, you're like, I hope my eczema doesn't come back, because if I do, it's gonna be a couple sleepless nights. What's gonna happen, even for the parents too. But if you look at generalized eczema, it's such an impairment of quality of life. It kind of trumps everything else except for cerebral palsy in terms of the impact of quality of life. So having just eczema, it's not a trivial thing. It can be a significant impact on quality of life of the kids, but also the families as well. Anytime you have a parent that tells you, yeah, my kid's not sleeping at night because of the eczema, that means the parent isn't sleeping at night as well, because they know it's happening. Sometimes they can hear, there's a parent who isn't, sometimes they co-sleep with the kids because they're itching, scratching so much, they try to stop them from scratching. But there's a parent's like, yeah, my kid's in another room, but I can hear him all night long. So it's terrible, when that happens. And it's important to ask about the quality of life. And here's a review meta-analysis fairly recently looking at the association of atopic dermatitis with depression, anxiety, and suicidal ideation. It can affect their lives in significant ways. And one company actually had this campaign where they made the world's most uncomfortable bed. They had a bed made of this like rough burlap, and they made the bed move around so you can't sleep very well, and they heated it up, kind of like, if you have eczema. And they actually had some bloggers kind of sleep in the bed and blog about what it's like, just to give people the sensation of what's it like to have atopic dermatitis. Sometimes if you don't have it, you don't know how bad it is. Tip number 10, this is the last tip, is use handouts and websites. It's good to counter the misinformation on the web. And sometimes, if patients are like me, I sometimes forget, things as soon as people tell me. It's good to have it written down. So the Society for Pediatric Dermatology, they have patient handouts that are free. Anyone can access this. And it's pretty nice in terms of this is the one for atopic dermatitis. They do it in a fairly coherent and a simplified way for people to understand. At the Children's Hospital, Wingfield has done a lot of work to revamp the dermatology website. If you go there and click on resources, you have patient handouts that are there. If you click the eczema one, because the atopic dermatitis one was an old one, which I used to fill in. The eczema one is the one that looks like this. It gives you like a 2-pager on what eczema is, but the flip side has an eczema action plan. It tells you different products you can use, but if mild, moderate, and there's a severe in the bottom. So if it's mild, this is what you do. If it's just dry, very little redness, just moisturize it. See if you get under control. If you can't, go to the next step. Or if it's itchy, go to the next step. And then you can circle what medications you want to use for the patients. And here's one from the Children's Hospital of Eastern Ontario. Michelle Ramin, who's now Peds Derm in Calgary, she used to be there. She put together this eczema action plan with pictures and stuff. And you can, they haven't, this is from, I think, their study, and they haven't, I think you can Google and find this, but it's really nice because you'll see pictures. It tells patients what to do, because oftentimes when they leave the doctor's office, it's very hard to remember everything that's been said. And sometimes it's nice to have something to fall back on. And she actually looked at the usability, satisfaction, and usefulness of the eczema action plan, so that, yeah, it really works and patients like it. So I'll summarize the top 10 points. Number 1, watch out for atopic dermatitis mimickers. A lot of things that look like eczema that aren't eczema. And make sure, especially if things aren't responding the way you expect, make sure it's eczema that you're treating. Education is probably the most important thing you can do for your patients, and it can be even therapeutic. Number 3, it's probably not the food. Number 4, counter medication phobia. Number 5, prescribe the right amount of medication, and you can check how much they, sometimes they're dispensed in smaller amounts from the pharmacist. It's good to have them bring in the medication. It's very useful to see what they're being dispensed and how much they're using. You don't need to limit the baths. Bring in the medication. You can also put it on the family for them to show them how much to put on. It's worth trying the swimming pool baths. Even with all the data that's coming out, I think it's still a worthwhile adjunctive treatment for eczema patients. And consider the impact of quality of life for the patients. It's very funny, like sometimes if I have teenagers that come in, I kind of expect that, sometimes they just don't talk very much. So the patient with eczema that came in, he had horrible eczema, but he just didn't say very much. Like, oh, okay. And I didn't ask him, if he felt depressed or not. But it was bad enough that they're starting the study on medication for eczema. So I said, hey, why don't you call this number? They might enroll you in the study. And as soon as they enrolled, they asked him questions. And the clinic, the study nurse said, do you know your patient is severely depressed? It's like, oh, I didn't even ask. But he was. And then that was like, it was impacting him in really, really significant ways. So it's good to ask the patients, how they feel and how it's impacting the quality of life. It doesn't necessarily correlate with the severity of their eczema. And there's some scores that you can even print online, which ask questions like, how many days of school have you missed? How many nights of sleep have you missed? How many activities that you like to do that you don't do? Because eczema is really funny. I find that patients with psoriasis, they're not as common, but if they have psoriasis, sometimes they'll do a lot of different things to get the psoriasis under control. I think the reason why is that the psoriasis isn't like a part of their life. They have their life, and the psoriasis is like, oh, it's inconvenience. I want to get rid of this. Whereas the eczema patients, they live with eczema, so sometimes it's really horrible, life altering. It's like we should go to something more. It's like, I don't know, what's the side effects? I'm not sure if I want to do that. Like it's infecting you so much. Like I don't understand why you wouldn't do that, but I think I understand now if you're living with it and you're coping with it. And sometimes you're like, I don't want to change anything to make things really bad because I know how it's like when it's bad. Sometimes patients just cope with it and they don't realize the impact of quality of life until they circle things like, oh yeah, I don't do this anymore because of eczema. I don't sleep very well. And they realize how bad it is for them. And use handouts and websites because it's really great that if you educate the family, but sometimes they don't. It's hard to retain everything that they're being told. And I'll leave up. But the teacher is one who makes him or herself progressively unnecessary, and that's the job in eczema. To teach the family. I tell them you're going to go through eczema school, but my job is to make sure you graduate with flying colors. And if you get it under control well enough, you don't even have to come back. But we'll be there to help you as you go on. So that's eczema. Top 10 tips. So open up to questions here, also questions from the webinar.
So if you do ask a question, there's this thing here. Oh, hello. So it turns red, and then
Solid red will be.
solid red, and then people on the WebEx will be able to hear you.
And because it just came out in the Journal of Continued Medicine Surgery, here's like the little algorithm that they put in there. It's kind of like almost hot off the press, but an algorithm for the treatment of atopic dermatitis. Yes, question.
I've been often hearing the importance of like drying the skin after the bath before putting the moisturizer. Is it really a thing?
Well, the question is like importance of drying the skin before putting the moisturizer. You don't have to dry the skin, but how you dry the skin is important. So if you rub with a cloth that's kind of rough, it's almost like scratching the skin. So oftentimes, if you're going to tell patients how to do it, just pat it moist. But you don't want them too wet either, because then it'll feel very sticky. Sometimes I reframe things. It's kind of funny. Patients sometimes have bad hand dermatitis, and I tell them, yeah, you want to moisturize after you wash your hands, but it's very counterintuitive, even for myself, if I moisturize, because I think, oh, my hands are wet, and I'm not done until I dry my hands. But for the patients, I sometimes reframe it to say, you can put a thick layer of either the medicine, if it's eczema, or a moisturizer, and then choose pajamas that you don't find getting sticky. Those will be your medication pajamas. So you put it on, it gets sticky, but okay, these are my medication pajamas. So the next day, even if you're too busy, you don't put it on, you put the pajamas on, like, oh, we got some medicine or some moisturizer. Or they can be your moisturizer pajamas. That way it reframes it. Oh, sticky's on, that's a really bad thing. But even for the hands, it's kind of reframing the brain to think, oh, this is an okay thing to do. But in terms of like, you don't want it wet, but having it moist is not a bad idea. You don't have to dry it completely before you put the moisturizer on. Yeah. Yes.
How much bleach in how much water?
Yeah, so if you want to do the exact calculations, about 120, basically it's for every milliliter of bleach, a liter of water.
Okay.
Yeah, but the simplest way to do it is
good
like,
to know.
about a quarter to a half cup, and it can be like a regular drinking cup, into a regular bathtub, which is about, like 3/4 full or so. So a lot of the families, what they say is the first time I ask them, so how do you put the bleach in? It's like, oh, the first time I put it in, I measured it exactly, put it in the water, I stirred it around. And then after a few days, I just the concentrations, if you look at the concentrations that are there, it's probably even lower than swimming pool water. And so when it came up, before recommending it to my patients, I have this thing where if you ever rotate it with me, I sometimes do to myself before I do to patients. So I put like double the concentration, I soaked in it. So you're supposed to soak in it for 5 to 10 minutes, soak in an hour. And it took quite a lot to even get a bit of irritation on the skin. So I realized, yeah, for the patients, even there's a lot of wiggle factor, and they're fine with that.
Thank you.
Lisa, you treated. How much has the incidence of eczema increased in the last 50 or 60 years? So I've seen one article a few years ago that was showing a quite dramatic rise.
Yeah, looking at the for the last 10 or 20 years, it's been fairly stable. But I think amongst different countries too, you'll see a difference in prevalence of atopic dermatitis. I think in North America, it's been fairly stable at this point. But the theories behind that are very interesting, from the eat dirt or to clean theory to other things. I think for the food allergy stuff, it's probably more than just the rural environment and the dirt, but the other things we're not too sure about, and it could be this Th1 versus Th2 balance that's there. And the theory, it's still not proven, but if you have more Th1 disease, like parasitic disease, viral diseases, these two parts of the immune system, they antagonize each other. So if you have more Th1 diseases, then you have less Th2 diseases. But once you eradicate those, you'll have more Th2 diseases. It's still a theory, I think, at this point, not totally proven yet. Yeah.
Another thing, do you think there's any value in putting things like alpha carry into water? Because I think it was one article a year ago or so that said it was not of any value.
Yeah, I think they actually there's a Cochrane review that came out to look at bath additives. So you can use like carry oil, you can use oil-latum, and these are emulsifying oils. So if you just pour, olive oil, actually, there's a study looking at olive oil in the skin, and actually it probably breaks down the skin barrier. But if you put sunflower oil or canola oil in the water, it'll all beat up because it's not emulsifying. If you have emulsifying oil, it kind of blends into the water, and if you get out of the bath, it kind of comes up and forms layer in the skin. So theoretically, if you're just talking about the skin alone, it might help, but the Cochrane review said it didn't really help very much. The second thing is that it makes the bathtubs really slippery, and it's a real pain to wash out. So I think for the amount of benefit that you may or may not get from it, it's not worth doing. I did have a family who told me that their secret for eczema was they used Glaxol base, the moisturizer, as a kind of like a soap for the kid in the water. But that's also kind of goofy, and so yeah, even for regular soaps, I think a lot of things are coming out these days saying that we don't really need as much cleansers or soaps as we're using. Mostly it's for the hairy areas which have oil secretion, and the dirty areas. Everything else, water is good enough to help these keratinocytes, break off and shed from the skin.
The same is shown really for shampoo, isn't it?
Yeah, for shampoo,
I
yeah.
haven't used shampoo for almost 2 years.
Yeah.
After reading an article in a British journal.
Yeah.
It actually makes no difference that you never have to use hair products because your natural oil return.
Yeah, they do. But then, it's how society changes. There's this great book, if you want to read it. It's called The Dirt on Clean by Karen Ashenberg. Yeah, so if you've read that, this is really fascinating. It talks about the history. The subtitle is An Unsanitized History, right? And she talks about even from the gladiator times, after they're finished wrestling, all the dirt that's there, they use a metal stick called a sturgill to scrape off their dead skin, and that's it. No showers in the locker room. That's all they do, right? To Napoleonic time, where they have a letter from Napoleon writing to his wife Josephine saying, "Honey, I'm gonna be home in 5 days. Don't bathe." I want to smell you. To these days, we're like, that doesn't really fly, right? We want to smell like nothing or smell neutral. It's interesting because you have masking fragrance and products to make it smell neutral. It's historically, we don't have to use all the things that we use. And just last year, there's a doctor a dermatologist in Ontario called Sandy Scott Nicky. She wrote a book called Beyond Soap. It's a really good book. Yeah, talking about products. She specializes in allergic chronic dermatitis. People who put products on get allergy to it. So it's called Beyond Soap. It's even on Amazon. It's a really great read, talking about you don't really need all the stuff that we're doing there. Actually, it goes through from a chronic dermatitis point of view, also from the historical point of view, where there used to be just one product you buy, but now there's so many SKU lines of different things that are there and how that came about. It's very interesting, but it's a fairly recent phenomenon. Even how you make soap is very interesting now.
Who's that author?
Sandy Scott Nicky. Yeah, Skotnicki. And if you look at how soap is made, use lye, Lye, ash, and fat together. It's very, very basic. And if you look at the skin, sometimes I watch commercials and then they say all these different things like, oh yeah, your hair, you want a good pH and stuff. But there's some truth to pH for the skin. The skin has something called the acid mantle. It likes a pH of around 7 or lower. But if you use soaps, think of someone with OCD washing their hands all the time, you really break down the skin by using that. It also activates proteases in the skin, which actually, as a tangent, is very interesting because if you talk about bleach baths, that's also very basic. But we find that the effects are not the same as using soap. Maybe there's a window where the proteases are active and the bleach changes that. But if you do that, it can be quite harsh on the skin. So oftentimes, if you see body washes, oftentimes they're made with synthetic detergents that are there that might have the benefit of you can make it at a neutral pH. They're detergents as opposed to true soap, and that make a difference as well. But the way we're cleansing ourselves, that might be causing or contributing a lot of problems, especially as you get older too, where you can sensitize your skin cutaneously and get allergic chronic dermatitis to a lot of products that are out there. Yeah, you probably heard, like parabens are like, the worst things in the world, but from a contact dermatitis point of view, it's not that bad. The literature isn't that strong on its estrogenic effects, but all you have to do to make the consumer avoid something is to make a product and say it's free of that, paraben free, must be bad. But there's a time where they replace paraben. Parabens are a preservative, so they replace it. It's not bad they replace it, but what you replace it with is very important. And for a time, a lot of products had this thing called methylchlorothiazone, this long multisyllabic preservative that was very sensitizing. And there's a time where you see patients without wet wipes, and they have that because it's water. You got to have something that stops it from growing bacteria and mold and stuff like that. And we saw some kids would have like a dermatitis around the mouth that's recalcitrant, around the bum, sometimes around the hands, everywhere you use wet wipes. And now they've taken it out. But it's kind of interesting how in the adult world, they have reports of it, but instead of calling it wet wipes, they call it moist toilet paper. It actually sounds really nice, but there's reports in the adult population of that happening as well. So what you replace it with and preservatives that are there, we can have a whole bunch of contact dermatitis cases that come up as well.
As hand washing rates slowly increase, are you in healthcare settings, do you see more and more healthcare workers?
Yeah, so as hand washing increases, well, not all alcohol rubs are created equally. And the ones we use here, which are the foaming ones, they tend to be not as drying. But if you use something like Perel, then that can be quite drying for the skin. But hand washing itself, going back to the eczema kids, I tell the family, because eczema can get better as they get older, but for lifelong, they will have that sensitive skin. So it's like, well, if your child's going to grow up and be a world famous chef or a world-class surgeon, they'll find that their hands are probably much drier and much more irritated than someone else who doesn't have eczema. But even if you don't have any phlegm deficiency at all, if you hand wash a lot, you're going to strip the natural fats from the skin and you're going to have dry, cracked hands. What you can do, however, is that as you wash off all the bacteria or all the dirt, all the soilage that's there in your skin and the fats, you can use like a moisturizer on top afterwards to replenish that. But if you don't do that, yes, your hands will get drier and drier as time goes on. Yes.
Do you have advice for your prophylactic moisturizer, like just Vaseline or Aquaphor? Because I guess you don't want to use something natural with a calendula. Like you could sensitize the child, right?
You can sensitize a child just about anything. And if it's a botanical, you're more likely to sensitize it because it's something biologically active. Interesting history about the history of petrolatum. It was initially used, it's an oil bioproduct. And I think at one point, right now there's this consumer group that does not pseudoscience, they actually look at real scientific articles and rate things called the environmental working group. It might be the bane of your existence sometimes because patients are like, well, it says the environmental group says this is bad. Petrolatum used to have a bad rap because they thought, oh, if it's contaminated by hydrocarbons, then hydrocarbons can be potential carcinogenic. If you look at the, like medical grade stuff, it's fine. So actually, even their group dropped petrolatum is fine. The problem is like how well it feels. So the story of petrolatum is that oil rig workers, it was like a secret amongst, not a secret, but they're like, yeah, whenever you have a cut or a crack, just use this, like this gook, this gunk and put on your skin and it heals great. And that's how petrolatum came about. It's like it was an oil company's byproduct that got refined and became like a product that we actually use. But at the end of the day for the patient, it's whatever, I sometimes look at the kid and I say, whatever she's willing to put on, look at the parents and what you're willing to pay for. But this is a case where I think having samples is very useful. I put the samples on the kid and I used to ask the kid, oh, which one do you like the best? But I find that's not a good way to ask him because like, oh, I like this, but I don't like this. I don't like this, I don't like this. Now I just put them on. It's like, hey, does it feel okay? Does it irritate your skin or does it feel fine? If it feels fine, like, hey, these are all one of the things that you can use. And just look for whatever's on sale, whatever you like. If they like all of them, you can use all of them. But for my daughter, my second daughter, she had really bad eczema. So I just used plain petrolatum Vaseline for her. And even today, she doesn't find it's too sticky. My other kids, they won't use it as a moisturizer. I have a funny story where for our oldest two who are girls, when they drop their nap, we instituted quiet time. So then they could, draw or read if they didn't want to take a nap. So we tried to do that for the boys. And once our youngest, Gabriel, he was in there, he's like super quiet. Like he's never quiet. Maybe he's sleeping. We won't rock the boat. And then he walks out on the landing. The tub of Vaseline was missing. and his hair was like just. So that's the only time that they'll use it. But for other kids, sometimes if they don't have that bad eczema, there's so many different elegant moisturizers that you can use, and it's finding something that I really like. But the kids have really, really bad eczema, and for some reason, I had some patients from the States. I'm not sure why, but the African Americans from the States, they use a lot of Vaseline. Even some patients, like there's one that moved from, I think, Chicago, where it's really hot and humid. You wouldn't use Vaseline, but yeah, that's what that is like. That we like Vaseline, we like how it feels. Some patients who have very cracked skin, the only thing they'll use is something that's like Vaseline because it won't sting their skin. But it's about finding something that they'll put on. The best moisturizer is one that gets on the skin, not the one that stays on the shelf.
Because the baby Vaseline has fragrance.
It does this fragrance, yeah. So one that's pink.
Yeah.
It's not. I think it says 99% petrolatum. Like, so it might be fragrance, not 1%. But the blue top one, it doesn't have to be Vaseline branded. It could be just plain petrolatum. But yeah, the baby one has that almost like that talcum powder smell to it. Yeah. And you do want to avoid, fragrance in the products because it could be one thing that irritates the skin.
Well, round of applause for our
Yeah.
speaker. I have evaluation forms. I don't know what normally happens, but I'm hoping you'll fill them out. And thank you so much for the incredible presentation.
Thank you.